Hi, I wouldn't be here for one reason, and that's because we lost our daughter um, 15 months ago. Um, we went to the cry unit and we discovered that my husband had neuroendocrine cancer. One of the doctors did look after us really well, but when we were referred on to an oncologist, we felt that it was very slow. And we had to fight for what we had, for what my husband had. We were told that he had the best of cancer that he could have, and we had biopsies done. Then after that, then we were told, and that's why I feel you do slip through the loop between doctors. Maybe the lack of communication, I don't know what. He started his chemotherapy. Then he was in hospital because of the heart, as we think that's what happened, my daughter, because it's quite severe on the heart, so they were just taking no chances. So he went in, he was complaining of his back on and off, so they decided to do an MRI scan, which he never had done. He had CT scans done. Then he came back and they told us then that he had a small tumour in his rib cage, which was fine, and they told us his cancer was non-aggressive. And then we were discovered this. My husband was very sick in hospital. He couldn't sit, stand, or lie. He wasn't sleeping. And I'm just disappointed with the system, as in when he complained and had pins and needles going down his leg, going across his back, they still discharged him and they told him that everything would be fine. And it was one of those things. It's probably because of his bowels not moving, or his bowels moving too much. So when we went back up to get another chemo, this is still in the first cycle, they went back and they looked at a scan that he had previously done about 2 to 3 weeks. And then they discovered he had multiple tumours on the lower spine. That wasn't picked up the first time, which is a bit disappointing, to be honest, after all that we have gone through. We were told then that his cancer, or his chemo wasn't working, that we needed to go on to plan B. But they decided then that we don't think we'll bother doing another biopsy on his back. And then we got a phone call on Friday to say, yes, we will do a biopsy. So we had a biopsy, and only because I met 2 other lovely people in our lives that had similar, had neuroendocrine cancer. And only for them people we wouldn't be here today, and we would have definitely slipped through the lines of doctors. We, thank God, got an appointment to see Professor O'Toole, and he told us to stay on the treatment. But I just want to say the lack of communication between doctors, so it's very hard because you don't know where to believe or who to believe. So we are on treatment at the moment. Please God, it'll go well. But we haven't seen our oncologist doctor since we went to Dublin. And I think it's so, not that we are with the best now, and I do feel we are, but it's just the unknown, that's all.
I think it's, it's obviously been a harrowing experience, and I'm sure many of you have had variations of that. I think it's really difficult to unpick your individual experience in this kind of forum, and you may find it's worth booking a slotting clinic to try to review what has happened, to help you work out why everything happened when it happened. I mean, I sometimes find if I've someone who doesn't do well, if someone doesn't survive their treatment, I often say to people, look, why don't you come back to clinic in about 3 months, to their family. Come back to clinic in 3 months, let's sit down, work it out, try and see what actually happened. And sometimes that's a good thing to do, not as part of your regular clinic appointment, but just a separate meeting to try to, give you the answers that you're looking for. So I think that's maybe a better environment to try to work out these kind of answers. One specific, maybe sort of biological point in the middle of all that, we base a lot of treatment decisions on biopsies. And that's kind of like the real banker kind of test, But one of the problems, and it can be a bit misleading, is that sometimes tumors have different bits of the tumor show different levels of activity. So a biopsy might tell you that the tumor looks like it's not terribly active, but there may be islands of higher levels of activity in other parts of the tumor that you don't know about until that patient's disease progresses quicker than you think. So that's a potential pitfall. I think that we're all aware of it, and I think we generally try to would have a fairly lower threshold for repeat biopsying. Now we're trying to get bigger biopsies to try to avoid that problem. But it's an issue. It may be one of the factors, that's contributed to the experience that you've had. But clearly there are others as well that could be worth teasing out in a different environment.
I think, though, it gets back to the point of, I like the way you phrase it, Justin. People will have had various degrees of that frustration in terms of what you're talking about is access to care, really, at the start, and access to quality care. You know what? We make mistakes as well. I like to hope and think that we make less mistakes because we're going through a formal process of all of the experts being together and listening as well. And I think that when you've got interactions with patient fora like this, Colm there asked a question about, about debulking and stuff like that. You're often in contact with other people, you're looking at the internet and all the rest of it, and sometimes we change our therapies because you come up with suggestions as well. And we can't be, you can't be so arrogant that you can't listen to people and advice from outside of your own multidisciplinary group as well and all the rest of it. So we're try to be as humble as possible as well, and know that, look at Per, I wasn't insulting you earlier on, but the expertise that you've brought to this internationally has been just absolutely outstanding. You and Kjell Ogberg and all the rest of it, and if we can get closer to that, that really is our ambition. We have room for improvement. And getting back to the access thing though, and Jerome, thank you, I think that's really an important initiative. However, in the meantime, it might be reasonable to write to the oncologists, or just to sort of say generally that maybe after Centre of Excellence accreditation, that that while waiting for money to follow the patient, in other words, that you won't get reimbursed unless it's done in a recognised centre. We know how long that can take in Ireland and many other countries as well, but maybe by stating that there is this, we can't force oncologists to send patients to us, of course, or to Galway, or to Cork, but the awareness thing is important. And I'd just like to follow on from Lisa said as well, in terms of, we're trying to develop here, and we've got now quality group involved in the net structure as well with us, that we'd have a more streamlined access with the net centre with a dedicated email to the administrator, so when Lisa's not there or I'm not there, that filters in, so to delay sort of appointments and all the rest of it. And what was the other thing, Lisa?
We were just saying the generic email and fax, because just at the moment the referrals are kind of coming in from everywhere, and they're going everywhere. So we'd just like to make sure that they're streamlined and sent to one centre, and then we could triage them accordingly, if they're urgent or.
And the other thing is that our junior doctor now, who's a net fellow, we call him, that Lisa's there on Thursdays and Fridays for the moment, but certainly Chin can field some questions that come through and try to respond to individual questions as well. So we're trying to improve that aspect of it. But look, I really sympathise with that, and it annoys me a lot, I have to say. And thankfully it's improved. But there's still room for improvement, a lot of room for improvement.
On that specific point, but just on the referral, we've had a very positive experience the last couple of years with electronic referrals from GPs to the breast, lung and prostate clinics, And what we did basically a number of years ago was actually work with the GP software vendors and build in electronic systems so they could actually, from a clinic, send referrals into the appropriate cancer centre, get acknowledgement that it's been received, and know that an appointment will be generated within a short period of time. That was years before the kind of more generic electronic referral systems have been developed by HealthLink across the rest of the HSE, but I think what we can certainly do is talk to HealthLink, who actually, their office is in the same floor as our office, to see if your particular service would benefit from kind of that approach. The next step beyond GP referrals is hospital-to-hospital referrals. Electronically, that's a bit more complex, but something they were actually considering at the moment, particularly for pancreatic cancer over the last number of months.